You tape. Oh, we're being recorded. Okay, we're very grateful to have the support of the Matthew Tabak Memorial Lecture Fund from the Division of Geriatric Medicine and Gerontology, as well as support from many of our participating programs, the Johns Hopkins Older Americans Independence Center and the Epidemiology and Biostatistics of Aging Training Program have been long-term sponsors of this series. So thank you again for that support and for showing up here today. It's my pleasure to introduce today's speaker, but before I do that, I just want to call people's attention to our next seminar series, which will be the first Monday in May 3rd. And we do have a speaker lined up on that date. It's going to be another speaker external to Hopkins. Jamie Justice from Wake Forest University School of Medicine is going to talk on May 3rd. And her topic is going to be clinical neuroscience, concepts, designs, and biomarkers. She was recommended by Ravi Varadhan, who I see is on today. So Ravi will be involved in introducing her and trying to promote that talk. But please try to join us on May 3rd at 3:30 for Dr. Justice's talk on clinical geroscience and clinical trials. So today we're fortunate to have with us Dr. Richard Fortinsky of the University of Connecticut. Dr. Fortinsky is a well-known scholar, has a number of diverse talents and experiences. He got his bachelor's degree a few years ago now at Pennsylvania State University in sociology. He then went on to graduate school at Brown University in Providence, Rhode Island, where he earned master's and doctoral degrees in sociology. After that, he took his first run of faculty positions at the University of Southern Maine in Portland, Maine, where he was a research associate, but quickly then progressed to become their director for their Center for Aging and Rehabilitation. After about 9 years in Southern Maine, he then took a position at Case Western Reserve University, where he was an associate professor of health policy in the School of Medicine there, and also got joint appointments in sociology and an epidemiology and biostatistics at Case Western Reserve University. After that, in 1998, he moved to the University of Connecticut, first as an associate professor, where he's rose up the ranks, and he's now an endowed chair and a full professor in the University of Connecticut School of Medicine. He has a number of grants, both current and completed grants. Some of his grants are rather large, and some of them were in collaboration with Julie Robeson, also at the University of Connecticut, who presented to our group about 5 years ago on work on the impact of Alzheimer's disease and related dementia on health-related outcomes and on patient-centered care for cognitively impaired older adults. Dr. Fortinsky has also served as the chair for the Gerontological Society of America work group on cognitive impairment detection and early diagnosis. Dr. Fortinsky, we've been having this seminar series since I came to Hopkins in 2012. It's usually a mixture of external speakers and internal speakers. About a year ago, because of the pandemic, we switched to Zoom. And you are, I think, the first external speaker who has agreed to try to navigate this via Zoom. So perhaps you can add that to your CV after today's presentation. But I want to welcome you and then introduce your talk. The title of Dr. Fortinsky's talk is Depression in Community Dwelling Older Adults, Insights from Ongoing Clinical Trial.
Okay.
Take it away.
Okay, thank you, David. All right, hopefully everyone can see my screen. I'm going to just hide this video. Okay, well, thank you very much. It's a pleasure to be here today. And I can say welcome to our home since that's where I am. So really happy to be participating today. I'll start off with disclosures. I have no financial conflicts. The study that I will be spending most of the hour talking about is funded by the Patient-Centered Outcomes Research Institute with great gratitude. And I have a disclaimer there that PCORI prefers that we always put right front and center. So the objectives for today, I'll provide an overview of depression in older adults just to kind of set the stage. And then I will get into the study, the 3D team care study, and I'll explain the rationale for the study and also the study design. And then what I'll do is, as you will learn, we're enrolling in that study older adults who have depression, but also possibly dementia and or recent delirium. But I will focus my emerging findings presentation from our study participants who have screened into the study for depression only, in other words, without cognitive impairment. And what I'll focus on, and these are all just interim preliminary findings, just to kind of give you a flavor of what we're starting to see in terms of statistical relationships. But because it's a clinical trial, I won't be looking at outcomes today, and we are still recruiting, as you will hear. So what I'm going to do is focus on some of our baseline data today to explain how depressive symptom severity according to age, sex, and self-reported financial strain among the older adults in the study. And I will also present some results on domains of disability and well-being using the World Health Organization disability measure according to age, sex, and self-reported financial strain. And then I'll just tell you a little bit about where we stand in terms of the older adults in the study with depression who were offered behavioral treatment, which I will talk about. And then I'll end by taking a slightly different turn and focus on family members of the older adults in the study and their depressive symptoms. And what I'll do is compare depressive symptom severity of family members across the types of older adults' cognitive vulnerability. So just a bit of an overview of depression in older adults. I have found this to be a really nice summary. This is from an article that was published now some years ago, but it really is nice in terms of presenting both protective and risk factors from a lifespan perspective for late life depression. So as you can see across the top are risk factors and when they might appear during the course of the lifespan. So, starting off when we're born with genetic predisposition for a lot of things, and some research has shown that there's certainly genetic predisposition to depression. And then stressful life events often begin early in life, and psychological characteristics might emerge as well in the earlier part of the lifespan, including neuroticism and perhaps depression that first appears in younger years. And then moving through middle and later life, anxiety may develop, as well as medical comorbidities such as cardiovascular disease, also diabetes, also obesity these days is becoming much more common. And then insomnia, and then the accumulation of stressful life events. And then, of course, losses, one might call them, begin to occur, which includes loss of loved ones, loss of work due to retirement. And then finally, cognitive impairment might appear as well. And I'll talk about the intertwining between depression and cognitive impairment for a bit here as well. Then in terms of protective factors, socioeconomic status is an important factor. As a sociologist, I've been interested in social determinants of health related to health and disease before they were called social determinants of health. And you'll see today that I will present a bit on a measure of socioeconomic status in relation to depression and other factors. And then level of education, educational attainment that for many people is done earlier in life could be a protective factor against depression. And then social engagement, a sense of mastery, and you can see the other factors there that are more protective factors related to depression. Clinically significant depressive symptoms are present in approximately 15% of community dwelling older adults. That's a round figure. It's an average figure across many studies that have been done on trying to determine the prevalence of depression in community dwelling older adults. And of course, the prevalence of depression depends on the sample, where the sample is drawn from. Oftentimes in clinical samples, you would find a higher than 15% prevalence of depression in a given older adult population. But when one looks across at some of the national studies of community dwelling older adults, 15% is a general average for prevalence. Now, it turns out that studies of depression in later life do not systematically report the proportions of cases that start earlier in life versus those that are late onset. So the age after which onset is called late actually varies considerably. So there's really no standard definition of early versus late onset because many studies don't even report differences. I'll talk briefly today about at the moment how we are distinguishing those concepts, and I'll also mention what we're planning to do in much more depth to try to really plumb the histories of the people involved in our study, enrolled in our study. And late onset depression might be a harbinger of cognitive dysfunction, or it might be a response to an accumulation of stressors and losses in middle and later life, or more likely it's a combination of both. And there's a lot of research going on in these areas of work, trying to understand how depression is related to cognition, as well as other factors. So depression presents differently in older adults than it does usually in younger adults. In older adults, there are a lot of somatic complaints that appear as part of a clinical presentation of depression among older adults. That includes sleep disturbance, fatigue, psychomotor retardation, a loss of interest in living, and hopelessness about the future. Whereas in younger people, often feelings of worthlessness and social alienation from peers is often mentioned in younger adults. But in older adults, you have different presentations. And subjective complaints of poor memory and concentration are often disguised as cognitive impairment, but it takes a good diagnostician to be able to distinguish whether an older person with subjective complaints of poor memory and concentration is actually exhibiting depression or true cognitive impairment. That's part of the clinician's challenge in later life. So just to give you a flavor of the types of research going on, just very briefly, when it comes to late onset depression and cognitive impairment relationships, it's been long known that a recent history of depression among middle-aged and older adults is associated with increased incidence of Alzheimer's disease. And you can see the citations here are from many of them are from more than 20 years ago. So it's been known for a long time epidemiologically, but the mechanisms remain unknown. It's not exactly clear why there is such a relationship, but there are many people studying this interaction, if you will, between depression and dementia broadly, or Alzheimer's disease specifically. It's certainly an area of study that has gotten much more attention since there's been so much more funding available through the National Institute on Aging, particularly in trying to better understand dementia and all of the related medical conditions around dementia. But one area of study that's received a tremendous amount of attention, really just in the last 5 to 10 years, is structural changes in the brain. And even though there were some early studies, it really has picked up over the last 10 or so years, particularly the hippocampal region. And I wanted to just point out the work being done by David Steffens, which is the 6th citation on this slide. David Steffens is the chair of the Department of Psychiatry at UConn. Many of you, some of you might know him. He is the chair of the Department of Psychiatry, as well as an expert in geriatric psychiatry. And he studies biological bases of interrelationships between dementia and depression. And quite honestly, as a sociologist, I'm learning more from Dr. Steffens about how the biology of the brain might affect diseases like depression and dementia. And depression may be a risk factor for later development of dementia, even when depressive symptoms occur more than 10 years prior to the onset of dementia. So there could be a lagged effect in terms of the relationship between depression and later dementia. And that's been known for a long time as well, as you can see by these citations. There are treatments for depression. Antidepressants work for older adults. Antidepressants work quite well for older adults. Yet there is a lack of treatment. There is under-treatment in the older adult population for depression. And besides medications, there are also many non-pharmacologic interventions for treating depression in older adults. So some of the reasons for under-treatment include a lack of primary care provider expertise in diagnosing depression, which goes alongside of other work that I do, as Dr. Roth mentioned, in the area of dementia. There's often a lack of primary care expertise in diagnosing dementia and differential diagnoses. Same is true of depression in older adults. And there's also a huge shortage of geriatric psychiatrists in the United States. So it's very difficult to find a specialist who's really expert at diagnosing depression in older adults. But also there's misinformation about depression, because still in some quarters, depression is viewed as a normal part of aging, and that is certainly not true. I think probably all of us know that, but that still continues to be in clinical everyday practice a barrier to under recognition and under diagnosis of depression in older adults. And depression may be misdiagnosed as dementia, just as dementia might be misdiagnosed as depression. So there's an awful lot of misdiagnosis that tends to happen. The time that it takes to gather a careful history and really try to disentangle what's going on between depression and also more medical comorbidities often presents challenges to particularly primary care physicians to do an adequate diagnosis. And then, of course, from the patient's point of view, there's a reluctance to disclose symptoms. One of the things that we have found in the study I'll be talking about today is that a lot of older adults really hide, even from their own family members, the fact that they are experiencing depression and depressive symptoms, even when they're under treatment, under a pharmacologic treatment. So depression among older adults does seem to be something, at least for a segment of the older population, something that older adults are reluctant to share with others. Now, when treatment is sought, or when we think about treatment, non-pharmacologic treatment, for 20 years now, there have been collaborative care models, evidence-based. They've been shown to be efficacious, and they've shown promise to address some of these factors, meaning a lack of primary care expertise and time. Although most of these collaborative care models in the area of depression have not yet really been widely replicated. So some of you will probably recognize the three citations here, all of which were published in JAMA, again, 15 to 20 years ago now. But there hasn't been a huge uptake yet of offering these collaborative care models within health systems. And so that continues to be a barrier, which is frankly, again, similar to a lot of efficacious non-pharmacologic interventions in the area of dementia care that have not yet experienced uptake and wide replication. So that kind of brings us to, well, one more slide, sorry. Public health implications of undertreatment, then we'll get to our study for today. Untreated depression among older adults is a risk factor for numerous adverse outcomes, and you can see what they are here. Suicide is obviously the most serious of the consequences of untreated depression. And suicide is particularly problematic in older men. Men aged 85 and older have among the highest suicide rates of any age and sex group in the United States. Also, non-suicidal mortality, worsening health status, and you can see the other adverse consequences of untreated depression and unrecognized depression. So the study I'm going to be talking about, it takes place in a Medicare Advantage population, and the collaborative care models that were tested 15 to 20 years ago were done primarily with primary care groups as collaborators and also home health agencies as collaborators. But collaborative care models for depression, as well as other aspects of cognitive vulnerability, have been understudied in the Medicare Advantage population. So that was part of the rationale for us developing the study that I'll be talking about for a while now. So the purpose of this study, we sometimes call it the care management study, sometimes the 3D team care study, is to test the efficacy of an in-home multidisciplinary team care management model. And the focus of this team model is on reducing risks for adverse outcomes in older adults with cognitive vulnerability, and also their family caregivers. So the primary research group based at UConn School of Medicine and also at the School of Pharmacy represents a partnership with one of the larger Medicare Advantage plans in the state of Connecticut. So we are partnering with an insurance company. And at least in my case, this is my first experience as a researcher collaborating with an insurance company. And we've learned a lot about exactly what some of those challenges are. So this Medicare Advantage plan is open to anyone, obviously, who's eligible for Medicare, but we are focusing on the population age 65 and older within the Medicare Advantage membership of this insurance company. So this study is designed as a randomized controlled trial in which we are comparing this team, the 3D care team, versus care management services that are already offered to Medicare Advantage members by this insurance company. And that's a telephonic-based care management program, which really doesn't have a focus on depression or cognitive impairment. So the growth of the Medicare Advantage population is one of the reasons why we decided to undertake this. Excuse me. So as you can see in this slide, the enrollment of Medicare Advantage has really ballooned in the United States. And so by the end of last year, nearly 40% of all Medicare beneficiaries in the US are actually enrolled in a Medicare Advantage plan. So many people say that this is the future of Medicare, and it's really rising fast. Yet not a lot is known about Medicare Advantage populations because their claims are not usually shared in terms of public use data files the way that Medicare fee-for-service claims are available to researchers. So this is a real advantage to us as a research team, being able to work with this Medicare Advantage plan and to take advantage of their claims data warehouse, which it'll become clear to you how that's being involved in our study. So just for definitions, cognitive vulnerability, when we use that term, we refer to cognitive impairment due to dementia or a recent experience of delirium or living with depression, which again will be the major focus today, which, as I've already said, is a known risk factor for cognitive impairment. And it's been shown by a lot of folks that cognitive vulnerability, whether you're talking about dementia, depression, or delirium, can lead to adverse outcomes for older adults. Then, of course, family members of older adults with cognitive impairment are at risk for adverse outcomes as well. So just a couple of conceptual frameworks here. From the older adult's perspective, cognitive vulnerability, if it's left untreated, could lead to a loss of function, a loss of coping mechanisms, which could be in various domains, which could lead to outcomes that represent threats to independent living, which could include persistent functional decline, greater risk for emergency department use, hospital admission, and nursing home admission. From the family caregiver perspective, their family members' exposure to stresses that are due to older adults' cognitive vulnerability and functional decline could lead to their own stress, and depending on their coping mechanisms and their desire for knowledge and skills, that might lead or that might buffer them from threats to their quality of life, or it may exacerbate their threats to quality of life, which are actually very similar to the kinds of threats to quality of life that are experienced by the older adults themselves who have cognitive vulnerability. And then finally, just from a systems perspective, you can think about a growing older population in general with increasing rates of cognitive vulnerability more specifically, which then leads to the need for appropriate services to serve that population, as well as the coordination of appropriate services in more local areas. And that's where models of care come in within existing service and reimbursement systems, or in a novel way, trying to test different coordination models in service and reimbursement systems. And then outcomes at the system level are often quality of care measures and also the cost of health services. So the aims of this study, there are several aims to this study because there are different target groups really. For everyone who's enrolled in the study who's an older adult, our primary outcome and therefore our primary aim is to determine the effects of the 3D team compared to the telephone-based control group on all-cause hospitalization or all-cause emergency department use without hospital admission over 12 months. So everyone who enters the study is in the study for 12 months. And here's where we're taking advantage of the claims data from the Medicare Advantage plan, because we are using as our primary data source to measure all-cause hospitalization and ED use. We're using the Medicare claims from the data warehouse. In terms of our second aim, this is where we distinguish those who come into the study with depression only and those who come into the study with dementia and/or delirium, along with possibly depression. But for those with depression only, our main outcome is depression severity over time and disability over time. And disability is measured using the World Health Organization Disability Scale. For depression severity, we're using the PHQ-9. The third aim is focused on the older adults with dementia and/or delirium. And for them, we're looking at their functional disability as an outcome, their quality of life, which is based on the QOL-AD measure, and neuropsychiatric symptoms using the neuropsychiatric inventory. For functional disability, we're using a caregiver-reported measure of functional disability that was developed by Dr. Laura Gitlin and her colleagues, and which we've used in another study with Dr. Gitlin. It's called the CAFU, the Caregiver Assessment of Function and Upset. And then we're also looking at outcomes to caregivers themselves. So we're looking at the effects of the 3D team on perceived well-being, on depressive symptoms, and caregiver burden. And aim 5, I won't really talk about it today as part of my prepared talks, but if you're interested in it in the Q&A, I'm happy to talk about it, where Pecori was particularly interested in this, outcomes of importance to older adults and caregivers. So just very briefly, as part of our baseline interview, we asked 3 different questions about basically how will you know that your health will be getting better over the next year. And so we basically take down the answers verbatim from the older adults and caregivers. And then 12 months later, at the 12-month follow-up, we read back to them what they told us, and then we ask them the degree to which they think they've achieved that outcome. And so there's a lot of qualitative data analysis that's going to go into analyzing those results. But it's actually pretty fascinating, some of the answers we've gotten. And then there's a feasibility and an acceptability aim, which really has to do with implementation, kind of drawing from implementation science. And then finally, there's a dissemination aim. So the major study entry criteria for older adults, besides age, as I already mentioned, is they have to live within roughly a 35-mile radius of UConn Health, which is where the UConn Center on Aging is based in Farmington, Connecticut. And we put that radius there because of the practicality of the distance of doing home visits. And again, happy to talk about that more if people would like to know. They have to have, the older adults have to have evidence of cognitive vulnerability symptoms. And in the next slide, I'll go into more detail on our 2-stage screening process. And you can see the other major study entry criteria, which are fairly common. The one about not diagnosed with schizophrenia or bipolar disorder, we really wanted to exclude people who have psychoses as well as we could based on diagnostic codes. And so they're excluded from the study. The 2-stage screening process involves an initial stage of identifying ICD-10 diagnostic codes in the Medicare claims data. And so anyone who has a record in a look back period that ranges from 1 month for delirium to up to 12 months for depression and dementia they're put on a call list, and I won't go into the many details, but Connecticut, the insurance company has people who work there who make the calls, and they screen people very briefly, and they just ask them if they're interested in being referred over to the UConn Center on Aging. And if they are, we get the referral, and our research team at UConn then coordinates an in-person assessment. And we can talk about the impact of COVID if you want on this later as well. But we do the assessments using 3 different screening tools, one for each of dementia, depression, and delirium, and you can see what they are here. And so at least one of these tests, any of these 3 screening tests in stage 2 has to yield a positive score in order for them to be eligible for the study based on cognitive vulnerability. So you can see we're using the telephone interview for cognitive status. We're using the CES depression scale as a screener, and then the informant version of the confusion assessment method for delirium. And then for caregivers, kind of a routine or conventional way of identifying caregivers: family relation or significant other of the older adult who's eligible, 21 years or older. And you can see some of the other eligibility criteria as well. And then we're using a stratified randomized design because we wanted to make sure that in each arm of the trial, we had roughly equal proportions of older adults who had depression only, meaning without cognitive impairment, and equal proportions who have dementia or delirium with or without depression. And it turns out that stratified randomized design has worked quite well for us so far. And I'll give you some numbers to back that up. Now, a caregiver is required to enroll in the study if the older adult screens in for dementia or delirium, but it's optional for the caregiver to join the study if the older adult screens in for depression only. Now, part of the reason for the optional for the caregiver gets back to what I said earlier about some older adults with depression really would prefer their family members not even know they have depression, or they don't really want to bother their family members, especially because for a lot of people with depression, they're not actually getting hands-on care from a family member or significant other. But if a family member and the person with the older adult with depression only agree, the family caregiver can join the study. And I'll talk more about that later on as far as the caregivers in the study. So I wanted to give you an idea of how this 3D team works, particularly focusing on the depression component. So the 3D team is led by a nurse practitioner. And there are other members of the 3D team, as you can see. So it's a multidisciplinary team that really focuses on risk factors for adverse outcomes. The nurse practitioner is the team leader, conducts all the clinical assessments that trigger referrals to other team members, and I will review those in just a few minutes. The nurse practitioner manages comorbidities and also manages urinary incontinence and sleep quality, because those are particular risk factors for delirium, for incident delirium in community dwelling older adults. The pharmacist is responsible for medication-related problems. Occupational therapists really are focused on the capacity of family caregivers, particularly of those who have dementia, and also the safety of the home environment. Physical therapist on the team is focused on older adults who exhibit evidence of ambulation disturbances and history of falls. And in red here, I kind of accentuated the licensed clinical social worker, who focuses on the older adults in the study who have significant depressive symptoms. We have a community health educator who focuses on more of the social determinants of health-related needs that people in the study, older adults in the study, might have. And then finally, a registered dietitian is responsible for focusing on nutritional adequacy. So here's how the nurse practitioner interventions work, again, with a particular focus on the depression component because of the topic today. So the nurse practitioner makes 4 in-home visits conducted over 3 months. The first 2 home visits are usually scheduled during the first month of the intervention. So, roughly 2 weeks apart. And then on a monthly basis, visit 3 and visit 4 are done. And then after that, the intervention turns over to monthly telephone calls. So the in-home part of the nurse intervention is kind of front-loaded, if you will, so that the first 4 to 5 months are in-home, and then for the remainder of the 12 months, there are monthly phone calls, following up on the problems that had surfaced earlier in the intervention period. So during the first visit, the nurse practitioner does extensive clinical assessments, which then guide referrals to other members of the 3D team. And during visits 2 to 4, the protocol that the nurse practitioner follows varies depending on which of the Ds, if you will, are present. So for those older adults who screen in the study for depression only, the nurse visits 2 through 4 are based on the depression care path protocol, which some of you might be familiar with, that was developed by Dr. Martha Bruce and her colleagues, probably about 15 years ago now, which really focuses on educating the older adult and a family caregiver, a family member, if the family member enrolls in the study, about signs, symptoms, and myths surrounding depression, strategies for reducing depressive symptoms through lifestyle changes. And again, these are components of the evidence-based care path protocol. And the nurse practitioner uses the Hamilton Depression Scale, the grid version of the Hamilton Depression Scale, at each of the 4 monthly home visits to monitor depressive symptoms in a clinical fashion. So this kind of widens out the focus in terms of what the nurse practitioner does in terms of referring to the other members of the team. So on the left-hand side here are the different team members. They happen to be in alphabetical order on this slide here. And then the second column shows you which of the study participants who get randomized to the 3D team are targeted for the different members of the team. And then the clinical and functional triggers that are based on the nurse practitioner assessments are in the third column. And then the nurse practitioner home visit when the trigger assessments are conducted. And then finally, just a quick synopsis of what the interventions are. So for the community health educator, all older adults randomized to the home-based care team are potentially eligible for the community health educator. And as part of the nurse practitioner's clinical assessment, we have a series of questions about unmet needs that might require community resources. And if any of those are triggered, for example, transportation needs or need for meals or help filling out insurance forms, things like that, housing problems, that they would get funneled to the community health educator if any of those items are triggered. And the nurse practitioner actually asks those questions during all 4 of the home visits in order to see whether anything new comes up in subsequent visits after the first one. And the community health educator does her work primarily by phone, but is available to do in-person contacts to address unmet needs. Now, the licensed clinical social worker focuses on significant depressive symptoms. So because problem-solving therapy, if you go all the way over to the right-hand side of that row, we're using problem-solving therapy as the non-pharmacologic intervention is what we're using. We're following the same criterion as far as the cutoff score on the GRID-HAM-D that was done by the original group that developed problem-solving therapy. And again, that was Martha Bruce and her colleagues as well. So in order to qualify for problem-solving therapy, even if you screen into the study with depression, you still have to have a GRID-HAM-D score of greater than or equal to 14. You also have to have a score of greater than or equal to 20 on the Montreal Cognitive Assessment Tool, because you have to have a minimal level of cognitive capacity in order to participate in problem-solving therapy. Now, the occupational therapist, I won't go through the rest of these in a lot of detail. I really wanted to focus on the LCSW work here. The occupational therapist works with the people who come into the study with dementia. And what we're using is a short version of the COPE intervention, which was developed by Dr. Laura Gitlin. And the nurse practitioner can refer that service to anyone with dementia. And again, everybody has to have a family caregiver if they have dementia. So that's their dyads, basically. And they would get referred to the OT who is trained in doing the COPE intervention. And the pharmacist I already mentioned. The pharmacist sees everybody's medications on a desk audit. The pharmacist does not make home visits. The physical therapist, you can see what the criteria are there for ambulation, impairment, both combinations of the timed up and go test and also falls history, which are done, the tug test is done in the home by the nurse practitioner during the first home visit. And what we've developed is an adapted version of something called the Otago exercise program, which was developed in New Zealand as a fall prevention program for older adults, and we've adapted it for in-home use. And then finally, the registered dietitian is called in if on a mini nutritional assessment, the score is less than 12, which is a signal for nutritional inadequacy. So just focusing just a bit on problem-solving therapy, for those of you who might not be familiar with it, it's 6 weekly sessions, and the first session is an hour, and the next several sessions are less than an hour. They could go up to an hour, but the average is 30 minutes. And they could be offered either in person or remotely. And we had arranged for a remote version of this even before COVID, like as part of our original design, because the problem-solving therapy intervention was actually tested using a remote, both in person as well as remote. And the citation that you see on the slide is where they report the results of the problem-solving therapy for remote use for homebound older adults. And so it's really focused, as the name suggests, on problem-solving ability, trying to work with the older adult to facilitate a problem-solving orientation, to encourage activity scheduling, and to facilitate compilation of a problem list that has some homework involved with it. And you can see really the 7 stages of problem solving on the right-hand side of the slide that the licensed clinical social worker is engaged with. So the LCSWs were trained in the use of problem-solving therapy before they started seeing subjects in this study. So they received by an expert in the field of problem-solving therapy. So turning to our recruitment goals and experience to date and getting to a bit of some of our early findings now. So our goal is to randomize 576 older adults and 380 caregivers. So we started recruitment more than 4 years ago. So it's been a very long recruitment period. Recruitment was suspended for nearly 6 months last year due to COVID. And as of the end of March, you can see the number of older adults who have been randomized into the study, as well as how many caregivers. And I was informed just today by our study coordinator that we reached 432 older adults just today. We randomized 2 older adults today. That gets us at exactly our 75th percentile marker toward our recruitment goals. So 75% down, 25% to go. And just wanted to kind of show you what a 35-mile radius around Farmington, Connecticut looks like. This is a map that's a bit outdated now, but it just shows you the geographic reach of this study. And we don't go into the state of Massachusetts, which is to the north there. So we stay in Connecticut, but you can see we go all the way down to the shoreline of Connecticut to the south there, which is where New Haven is. And so that's Long Island Sound down there below Connecticut. And we go into some rural regions, both to the northwest and to the northeast of Connecticut. So it really is quite a diverse population when it comes to geographic location. We have urban, inner city urban dwellers from Hartford and Watertown, for example, and also New Haven. And then we have some fairly rural areas as well. And Farmington is right smack in the middle of this circle. And so this is what the numbers look like. I'll be reporting mostly on the 199 of our 430 older adults who screened into the study for depression only. And you can see the distribution of the other types of Ds, if you will. So we definitely have other older adults who have depression who are in the study, but they have a coexisting cognitive vulnerability as well as depression. So you can see depression and dementia, for example, 75 people screened in for that. But for today, I'm really just focusing on those who screened into the study with depression only, with no cognitive impairment. And these are the baseline characteristics of those 199 older adults who came into the study with depression only. You could see the majority are female, and you can see the age group. I distinguish the age groups in a slightly different way, being a sociologist. I'm interested in the boomers versus those who are in the older generation from boomers, rather than kind of the conventional 10-year groupings of age, because this, a lot of people are talking about the boomers, and do they represent a different a set of risk factors health-wise for disability in later life compared to the older generation above them or not. So we're going to be looking at the data this way. So as of right now, the people who are at least 65 and older, since we started the study, you can see the years in which they were born, which roughly corresponds to the first half of the baby boom cohort or generation, if you will, because it went until about 1964. You can see one of the limitations of the study is that it's primarily a white population. This Medicare Advantage plan, actually, as is true of most Medicare Advantage plans, have not recruited heavily from the African American or the Latino or other underrepresented minority populations. But certainly this particular plan in Connecticut is majority white, vast majority white. And so our study population reflects that. And like I said, that is a limitation of the study. But we do have quite a bit of variation when it comes to socioeconomic status, both in terms of educational attainment and also level of financial strain, which we are measuring using a single item, which asks a question about, do you have enough money to pay for the basics such as food, housing, medical care, and heating? And this comes from the literature. And for any of you who might be interested in a citation for that, I'd be happy to send that to you. But you can see the distribution here for these 199 older adults in terms of their response to this question, across from not difficult at all paying for these to very difficult. And so we'll be looking at this variable very shortly in relation to depressive symptom severity, and also to the domains on the World Health Organization disability scale. And this just shows a few different ways that we could measure depression in this study. So I mentioned earlier about early onset versus late onset depression. We aren't showing a specific measurement approach for that right now, although we are going to be looking in great depth at the history of depression among the people in our study to be able to categorize them further. But for now, we're looking at the ICD-10 code that brought people into the study. And those of you who know the coding system, you know that there are a series of ICD-10 codes for single episode depression, and there are also a series of codes for recurrent depression. And we wanted to distinguish those for purposes of looking at how they might compare to each other in terms of some other factors. And so that's what we did for today. In terms of this remaining group of no depression code, so these are people who did not get referred to us with an ICD-10 code for depression. However, when we did that second level screen, we found out that they actually had considerable depressive symptoms measured by the CESD. So if they had a 16 or over. And so that's that smaller group. And then looking across everybody for whom we have a CESD score, you can see the mean is quite high, with 16 being the general cutoff for being associated with clinical depression. And you can see that 70% of this group of 199 have a CESD score greater than or equal to 16. The mean PHQ-9 score you can see is there, along with the categories of the PHQ-9. And again, that's being used as an outcome measure, the PHQ-9. And then about 17% so far of those with depression only have expressed suicidal ideation, and that is based on their response to the final item in the PHQ-9, which does ask about how often have you had thoughts of hurting yourself? And any answer other than never is considered suicidal ideation. And like any study that's capturing this information, we do have a suicidal ideation protocol that we follow if somebody does trigger that particular item. So I want to just start off by showing you in terms of findings here, just the correlation between the CESD and the PHQ-9. So, the correlation of 0.63, you would say, well, that's fairly strong, but it's important to point out that they are usually collected on the same day. So except for a few instances, we collect this information during the same session with the older adults. So the CESD is collected as a screening measure after we consent them. And then as part of baseline data collection, we collect the PHQ-9. And so you can see, they are highly correlated, but they're not what some statisticians might call strongly correlated. So there clearly are some aspects of these two scales that are measuring different underlying constructs such that they're not perfectly correlated or correlated at a higher level. So now I'd like to just present a series of box plots in which we're looking at different relationships. And the first is depression symptom severity by age group. And here we're comparing the boomer generation, which is on the right-hand side, the right-hand box, to the older generation, which is in the left-hand box. And so all of these are non-parametric tests. And so all of these slides will report the Kruskal-Wallis test for median differences. So what you can see here is the boomers actually, on average, do have a higher level of depressive symptom severity. And this is based on the PHQ-9 compared to their older generation counterparts. And here, depression severity by level of financial strain, you can see that the greater the financial strain, so going from not difficult at all to pay for very basics like food, et cetera, to very difficult for paying, you can see more or less a linear relationship, but certainly you can see the cut point at somewhat and very difficult on the financial difficulty scale is associated with a higher score on the CESD, and you can see the p-value of 0.03. So the next several results, we're going to look at gender and age, and that financial question in relation to I'll start calling it the WHODAS now. So that's the World Health Organization Disability Assessment Scale. And so the way the WHODAS works, for those of you who aren't familiar with it, we're using the 36-item version, and it's focused on the past 30 days. That's the reference period. So for all of the 36 items, the respondent is asked their level of difficulty with regard to the items themselves. And so higher scores on the WHODAS represent greater disability. And there are 6 domains of the WHODAS, and you can see them listed here: cognition, through mobility, self-care, getting along, life activities, and participation. So, and this has been extensively tested for psychometric properties, the WHODAS, according to these domains. And they cover a wide range of domains of health and disability. So we wanted to see if in this study cohort where everyone is screened in for depression only, do we see any effects on these WHODAS domains of age, sex, and financial strain? So that's what really we're going to be looking at. So first of all, the cognition domain according to sex, here we see that males compared to females scored slightly higher, which meant that they had slightly poorer cognition or had more difficulty with cognition-related activities compared to females. And this is the getting along domain. And again, the getting along domain has to do with interactions with both familiar people and strangers, and also maintaining friendships. And again, a higher score means more difficulty. So males compared to females, again, within this cohort of everyone having depression, report more difficulty in the getting along domain. And this is the cognition domain by level of financial strain. So the next few are going to look at level of financial strain as a factor. So the cognition domain had a fairly tight level of variation, but so even though the median differences don't look all that stunning when you look at them as meets the eye, you could see that certainly there's an upward trend toward those who report somewhat or very difficult in terms of financial strain, also report higher limitations on the cognition domain. This is the self-care domain. Nearly everybody reported, very good ADL, IADL type performance as far as this particular cohort goes. But you could see a trend toward those who report more difficulty in terms of financial strain do have slightly higher scores on the self-care domain, meaning they have more limitations in the self-care domain. And the same trend here with the life activities domain score by level of financial strain. And this has to do, the life activities has to do with household and work-related activities. And you can see, quite a jump for those who say very difficult in terms of financial strain are have the highest levels of life activities difficulties as well. And then the participation domain, which has to do with limitations imposed by the environment and the impact of health on others, that particular domain of HUDAS, you could see, again, that same gradient that we've seen for all of the other slides related to financial strain. Those who report the greatest level of financial strain also report the greatest level of difficulty when it comes to the participation domain of the HUDAS. So just to summarize what we've seen so far, the two measures of depression that we're using are moderately associated with each other, but they have different associations with characteristics of the older adults with depression in the study. And then among the older adults who have depression, the 199, we found that the boomers have higher levels of depressive symptoms than their older generation counterparts, and that greater levels of financial strain are associated with both higher levels of depressive symptoms, as well as greater difficulty in several domains of health and disability measured by the HUDAS. Interestingly, we did not see any differences between older adults who had the code of single episode depression versus those who had an ICD-10 code for recurrent depression on any of the HUDAS domains or on the severity of depressive symptoms. So just looking at the diagnostic measure alone did not really differentiate any of the HUDAS domains. So turning now to problem-solving therapy experience. So of the 199 older adults who have depression in the study, 99, or almost exactly half, have been randomized to the 3D team. And so of those 99, again, they have to be eligible for problem-solving therapy once they are assessed by the nurse practitioner based on their GRID, HAM-D, and MOCA scores. So 79 were screened out of the 99 who were referred to get the problem-solving therapy. And you can see that the acceptance rate was modest. About almost 70% of the 79 people, older adults with depression who were referred, accepted problem-solving therapy, and they initiated the intervention. So this is where you get differential acceptance of getting a therapy like this. And of the 54, 43 completed either 5 or 6 PST sessions, and 3 remain active at this point. And again, we're not looking at outcomes yet. We're not really looking at the impact statistically of having received problem-solving therapy, but we have actually quite a bit of anecdotal evidence from feedback we've gotten from the older adults with depression in the study that they've really benefited from the problem-solving therapy intervention. So in the final part of the talk here, I'm just going to focus a bit on the family members now. So what we're going to do is look at depressive symptom severity among the family members of older adults with cognitive vulnerability. And this is one of those conceptual frameworks I showed earlier, just to kind of remind you about the family caregiver's perspective on their relationship with relatives with cognitive impairment and how that might lead to poor outcomes. So many dementia care interventions that is, have targeted family caregiver depression as an outcome. But less is known about depressive symptoms among family members of older adults with depression and/or delirium. So particularly when they're compared to depressive symptoms among caregivers of older adults with dementia. And the purpose of this little exercise here, which again is interim findings because it's based on just a portion of the sample that we've accumulated in the study so far, is ultimately to help inform interventions for family members of older adults with depression, particularly, and possibly depression mixed with delirium as well. So these are the 3 research questions guiding this work. And so we're interested in what's the level of depressive symptom severity among family members based on the combination of Ds, if you will, that the older adults who are in our study exhibit, the type of cognitive vulnerability. Secondly, we wanted to look at the association between family members' depressive symptom severity and older adults' dementia symptom severity. And then finally, the association between family members' depressive symptom severity and older adults' depressive symptom severity. So that's really what we've done here. So these are the methods. And I already mentioned about family members. So it's only the family members who agreed to join the study, along with their relative with depression, who are included in this analysis. So this particular sub-study, if you will, is based on the first 259 dyads of older adults and family members who were enrolled in the study. And we classified them into 4 groups. The older adults with depression only, that's who we've been talking about throughout the presentation today. But we're going to compare the family members of older adults with depression only to the family members of older adults in these other combinations of 3Ds. And we're measuring family members' depressive symptoms based on CESD data collected during baseline interviews. So again, this is all baseline cross-sectional data. And the CESD, by the way, is the outcome measure that we're using for the family members related to the specific aim for family members in the broader study. So this is for the 259 dyads that are in this particular sub-study. You can see what the distribution is on the various socio-demographic characteristics. So you can see the cognitive vulnerability groups, the numbers that are in each of the 4 cognitive vulnerability groups that we're comparing to each other. And then as far as the caregivers themselves go, you could see the relationship to older adults. So spouses are the predominant family member who's enrolled in the study, followed by daughters or daughters-in-law, and then other relatives or significant others. And you can see that the mean CESD score for the caregivers overall, for all the 269 in this sub-study, was an 8.4. And you can see the number of hours per week providing care. And so you can see that 50% provided less than or equal to 8 hours a week of care. And a lot of the family members of people with depression reported sometimes 0 hours of care per week because, again, they might not have been providing any. But it goes all the way up to 25% of the caregivers who reported greater than 40 hours a week. And obviously, those are the caregivers whose older adult study members have dementia. So we did some regression analyses here, and in all of the models, the dependent variables, family member CESD score, and the covariates, you can see what we used as covariates. So for research question number 1, this is where we're comparing the cognitive vulnerability groups to each other in terms of the CESD depression score. So the depression-only group is the reference group. So the estimates that you see here, and these are unstandardized regression coefficients, are comparing the groups shown in the model with those with depression only. So what you could see here, based on the fact that all of the coefficients are negative, is that all of the other cognitive vulnerability groups have CESD scores that are less than the CESD scores for the caregivers of those with depression only. And the only statistically significant one of those is comparing those, the caregivers of those with dementia only to the caregivers of those with depression only. But it's in the direction of the caregivers of the older adults with depression only having significantly higher depression scores than the caregivers of the older adults with dementia only. And then you can see how the other covariates are associated with the CESD scores. So here we are looking at the extent to which caregivers' CESD score is associated with dementia symptom severity of the older adult. And this is based on their TIC score, the telephone interview for cognitive status score. And again, controlling for the other covariates that I mentioned earlier. And here you can see that there's essentially no association between the depressive symptom severity of caregivers and the dementia symptom severity of the older adults in the study. And then finally, when we look at the older adult depressive symptom severity in a different model, in relation to the caregiver depressive symptom severity, we see that controlling for the covariates, there is a statistically significant association such that those family caregivers who have an older adult with depressive, the more depressive symptoms for the older adults, the more depressive symptoms for the caregivers. And we did not see that with the older adults' dementia symptoms. So just to summarize, after controlling for important covariates, the family member depressive symptom severity was most severe when the older adult had depression only, and was actually least severe when older adults had dementia only. And we also found that family members' depressive symptom severity was not associated with older adults' dementia symptom severity, but was significantly associated with older adults' depressive symptom severity. So in terms of conclusions and implications for this part of the presentation, family members of community dwelling older adults with depression are understudied, but they're at risk for depression themselves, as we've seen here. And although there have been some interventions developed and tested for family members of older adults with depression, there aren't nearly as many as there are interventions for family members of older adults with dementia. So it's a fruitful research area. And a clinical implication of this might be that family members should be screened for depressive symptoms when their older relatives have depression. And that's all. So I just really wanted to acknowledge my co-investigators, as well as everybody who's in the study as participants, our research staff at the UConn Center on Aging, all of the interventionists, and our Medicare Advantage insurance company collaborators. So thank you very much for your attention.
Well, thank you, Rick. This is the part of the meeting where you'd be getting thunderous applause if we were all in a room together. So yeah, some people know how to do symbols and stuff, but thank you for that very informative and great description of what sounds like a careful and super study that is ongoing. And I think we have about 20 minutes here for questions. The way this has worked in previous meetings is if people want to ask a question, put in just a few words in the chat section. I'll call you out and then you can perhaps phrase a longer question for Rick and then he can answer while I keep an eye on the chat box for future questions. I know that we had a few comments while you were speaking. Oscar Flores had, I think, a question, as did Robbie Vardon, about your different depression measures and how you define depression. I think some of that you ended up answering in your talk, but Oscar, do you want to chime in and maybe clarify your question or ask something related to that?
Yeah, thank you. Thank you, Dr. Rick. I'm just curious because when you use one screening questionnaire for the screening, and then for the change you use another one, PHQ-9, and then you also compare the correlation between the HAM and the PHQ-9. So I was a bit confused. Why you use different instruments?
Okay, yeah, that's a good question. So, well, we use the CESD as a screener because that's a common test that's used as a screener in studies where older adults are being recruited into studies. But the PHQ-9 is a measure for older adults. When you look at change over time in the PHQ-9, that's being used more and more in clinical settings as a measure of depression. So that's why we use two different measures for older adults. We use the CESD purely as a screener, and then we use the PHQ-9 as the measure of the outcome. So we're going to look at changes over time in the PHQ-9. The CESD we only collected for the older adults at the time of screening. So that's why we did that.
Thank you.
Thank you. You're welcome.
While we're waiting for someone to show up at the chat box, I'll ask a question or two here, Rick. One thing I noticed, and I'm glad you actually were careful with your terminology toward the end, as I think you mentioned, many of the family members of people with depression only may not qualify as caregivers. If you define caregivers as actually helping with an ADL or an IDL, so you're really comparing family members. And you know, on the surface, it might be surprising that, you know, caregivers of dementia are doing better than family members of people with depression. As someone who studies sort of the positive aspects and the benefits that certain caregivers get, I'm personally not surprised, but I think it is an interesting finding, and that you're carefully navigating your words there as you go forward with that. Assuming that holds up, that's going to be, I think, an interesting study as we, you know, continue to develop a more nuanced picture of what the family members of older adults experience and how we can best sort of talk about them and help them and screen them when necessary. So I'll put a question mark behind that and ask you to comment.
Yeah, sure. Well, this is an example of listening really well to your research staff, and you'll wonder, where am I coming with this? Well, you know, we have weekly meetings, like a lot of clinical trial teams have weekly meetings, and the research assistants mentioned to us probably a year into the study that when they went into the homes of older adults who ended up screening for depression, they felt a palpable pall in the house. They felt like it was gloomy in there. And they also tended to find that the family members, whether it was often a spouse, but sometimes an adult child, often seemed to be in a blue mood as well. And they said that was really surprising to them, because they had heard so much, and they had, you know, certainly, you know, read my work, they've read other people's work about how caregivers of older people with dementia often have depressive symptoms. And so this kind of caught them by surprise. They really weren't expecting to find this. And I said, well, we could actually test out your hunch empirically. And so that's really what took us down the road of starting to look at our baseline data to try to get a handle on this. And indeed, you know, the hunches of our research staff tended to play out, you know, in terms of the findings that we've got so far. And so that's really where it started, to be perfectly honest about it. So we really try to listen carefully to our research staff when we talk about, you know, what would have been your experiences and things like that.
Yeah, that's great. I'll ask another question. Oh, we have a chatter. Thank you. Let's see who this is. Yeah, Laura Samuel, take it away. Ask your question, please.
Yeah, thanks, Rick. I was just curious if you had thought about whether down the road you want to see whether the effect of the intervention differs by financial strain. I could see it going either way, really, but just curious what your thoughts were.
Yeah, that's a great question, Laura. Thank you. Yes, I mean, honestly, starting to look at the data, honestly, for this presentation is really when I really started looking at it. That is certainly a subgroup analysis that we would like to pursue. You know, we obviously have to be, this is not an a priori subgroup analysis that we will be doing. This will be post hoc, but it certainly is fascinating to think about how, and again, the other thing to remember is this, again, that this is a racially and ethnically homogeneous population. And so it shows even within a homogeneous population, if you will, from a racial and ethnic point of view, you're seeing these gradients by socioeconomic status. And so, you know, based on this, this kind of interim evidence here, absolutely, we would want to take a look at whether there's some kind of a moderating effect, particularly, of financial strain on the impact of the intervention. So yeah, thanks for asking that.
Next up, we have Has a lot of experience on complex randomized trials and monitoring those and implementing those. So George, I think you have a great question. Go ahead and articulate it.
Yeah, Rick, really enjoyed your presentation. And this is an intervention-related question. Just in terms of how you monitor such a complex intervention where you seem to have, multiple interventionists and lots of interconnected parts. And how do you sort of monitor whether it's being, delivered with a high degree of fidelity? How are you tracking actually intervention delivery?
Good question, George. So, so the fidelity for the occupational therapist, the physical therapist, and the problem-solving therapist are being monitored. We do have consultants on the study from outside of UConn who are experts in those interventions, and they meet regularly with the interventionists. They're all keeping intervention checklists, which are reviewed by our study coordinator and also by the consultants that we're using. So we're monitoring fidelity both just in terms of are the objectives that are in the intervention manual for each session, whether those objectives for each session are being met, and also whether and nobody enters the study as an interventionist until they are trained and receive kind of the seal of approval from the interventionist. As far as the nurse practitioners go, I work mostly with the nurse practitioners and in terms of just monitoring what they're doing and how well they're doing. And then they also meet with a geriatrician and a geriatric psychiatrist on the team to review their clinical assessments. And they also keep track, they also do an intervention checklist, a visit by visit and telephone by telephone contact checklist. So the short answer is we do a lot of fidelity checklists, and then we also do a lot of reviewing of case studies, again, particularly with the PT, the OT, and the problem-solving therapist. So those are some of the ways.
Great. It sounds like it's all manualized and you've certified people and really tracking.
That's correct.
Yeah,
that's correct, George.
Yeah.
Mm-hmm.
Great. Well, thank you.
Sure. Yeah. Thanks for your interest. Sure. Thank you.
You bet.
Rick, I have probably a couple more questions actually related, and it might be, asking for your expertise outside of what you're doing in your specific study. But you mentioned early on in your talk about the effectiveness of antidepressant medications for this population, and I'm sure the thought has crossed yours and other minds about some sort of economic comparison of the effectiveness of these non-pharmacologic behavioral interventions versus just antidepressant medications. And then the other side of that question is I work with people in geriatrics, especially for people with multiple chronic conditions who have an emphasis on de-prescribing, seeing which medications we can actually get people off of. And I'm wondering where you sort of conceptualize antidepressant medication in the clinician's toolbox for older adults with depression and possibly with a number of other comorbid conditions.
So the pharmacist on our team, as I said, monitors the drug regimen, which is fixed in time. It's when the older adults enter the study for based on the Beers criteria. And so the Beers criteria often look at use of antidepressants either on their own or in terms of their interactions with other types of medications that they might be on, in terms of safety, efficacy, and things like that. And actually, the pharmacist is the first author on a paper, which I'd be happy to send to you, where she looked at the first 105 older adults who came into the 3D team in terms of the safety and efficacy of the medication regimen that they were on. And one thing I did not talk about was, as part of the intervention, is a letter is sent to the primary care provider of the older adults in the study based on the medication review and by the pharmacist on the clinical assessment done by the nurse practitioner. They don't change the medication regimen, our 3D team. It is a consultation team, but they do recommend either considering antidepressants or considering tapering antidepressants or considering tapering other medications that might be interacting pharmacologically with antidepressants as part of the letter that goes to the PCPs. In terms of cost analysis, PCORI doesn't allow cost effectiveness analysis, as you might know, or some of you who might have some experience with PCORI. So we always have to be really careful about couching anything we do as something other than cost effectiveness analysis. But because we do have access to the Medicare data warehouse, so we actually could look, and we plan to look at the medications from the claims data warehouse in both arms of the trial. And so we're planning to look at that combination. I'd not thought about this trade-off, as you said, between pharmacologic and the non-pharmacologic interventions. That's something we might want to talk about offline, quite honestly, because within the group that's getting the 3D team, you've got different combinations of people who get problem-solving therapy and those who don't, and then some, and that's like a 2x2. Some who do and some who don't, and then some who are on antidepressants and some who aren't. So conceivably, I could visualize kind of a 4-group kind of an analysis that we would never call cost effectiveness, but we can look at it in relation to something. No, we can look at it in relation to health service use outcomes, for example. Yeah, good question.
We have a few more minutes if anyone else wants to chime in here in the chat box and ask Dr. Fortinsky a question. Okay, well,
Right.
oh, excellent.
So sorry
Oscar,
for
go
asking
ahead.
again, but I'm very interested in the topic. And my question was about I was thinking as a sociologist, or if you would like to include something in the future, or you would like to add something else apart from individual and familial level, and maybe another level of intervention. Because I usually think that intervention to depressions are focusing individual, and I think that's great that now is also included the familial. But I don't know, I was thinking if it is possible to then expand to something more. And the other question is related to loneliness. I don't know if this is also measure loneliness, or how to reduce, because it's a symptom and also a pathway for depression.
Good question about loneliness. We are not measuring loneliness in this study. Obviously, since COVID came along midway through the study, I wish that we had been measuring loneliness or something close to it, but we are not. But in terms of kind of the long-term aim at a system level, if we could show that this 3D team does have an impact on hospitalization and ED visits in terms of avoiding them, the idea would be for Medicare Advantage plans to think about some sort of an intervention that could be similar to this for their populations that have cognitive vulnerability, meaning their policyholders who have cognitive vulnerability, because depression and dementia particularly are not really part of your normal care management program that's offered by a Medicare Advantage plan, or many health systems for that matter. The focus is, on heart failure, on diabetes, on COPD, and things like that. Even though it's known that cognitive vulnerability, it has an independent contribution to healthcare expenses. So, part of what we want to do is see, without doing a formal cost effectiveness analysis, just see if these outcomes that are obviously adverse outcomes to older adults can be avoided using this 3D team intervention. And then the insurance companies could run the numbers themselves and look at cost savings that way. But that's kind of at the system level, kind of the biggest long-term goal is to try to incorporate more of a cognitive vulnerability focused collaborative care intervention for Medicare Advantage plans to use. This one might be too resource rich, but there may be components that might end up being appealing to Medicare Advantage plans that they don't do right now at all. So,
Awesome, thank you so much.
Sure, thank you very much, Oscar.
Rick actually thought of one more question, and believe me, I don't usually dominate the Q&A period, but I feel like I am today. Your family member analysis, remembering that all your participants who have dementia or delirium, a family member has to enroll. but it was optional for those with just depression. So there you have kind of a selection issue to deal with there, and
It's true.
possibly a factor explaining why the depression family members are more depressed. And is there a way to adjust for that if you think it isn't a selection issue?
I mean, it might be a selection issue. As far as how to adjust for it, I'm not sure about how to adjust for it, quite honestly. We'd have to kind of think about adjustment factors. But I think that the real issue is to really try to understand what, I mean, there's, you know, there are psych theories about kind of, you know, one person influencing the other person in a dyad, and, you know, kind of depression in one person builds in depression on the other person. So I think just trying to explain the association itself in more psychological terms, not so much sociological terms, I think is probably where we will go in terms of interpretation. In terms of trying to explain the selection effects, I don't know if we're going to be able to quantify the selection effects, but it had occurred to me, there's no doubt about it, David, that it's possible that family members of those older adults with depression only who decided to join the study did so partially because they are really feeling depressed themselves because their relatives are depressed, and they sure hope something helps them.
Yeah.
And helps them both.
Yeah,
So,
one thing I'm thinking of just on the fly, and it's always dangerous to have solutions on the fly, but maybe a sensitivity analysis just with the spouses and all the groups. I imagine most, maybe not all, but probably most of your spouses even in the dementia group are joining. So, and I think you're right that might be the sort of, you know, people tend to be married to people who are similar to themselves, and then you even get more similar over time. So if one person's depressed, the other one might be as well. Anyway, that's just one that you might consider.
Yeah, well, no, thank you. Thanks a lot. And, you know, my email address is on the slide set. Anybody should feel free to get in touch with me at any point if you have further questions. I'd be happy to talk with you. So,
All right.
Yeah.
Well, thank you so much, Rick. A fantastic presentation. And thank you all for joining us today. Do remember that 4 weeks from today is our next seminar. Jamie Justice from Wake Forest will be speaking on geroscience or clinical trials in geroscience, concepts, designs, and biomarkers. I do appreciate everyone showing up, and have a great spring.
Yep. Thank you, everyone. Thanks so much, David, for inviting me. All right. Take care, everyone.
Bye.
Bye-bye.